So thanks a lot. Okay. Okay, donc, thanks a lot. Good afternoon or good morning, everyone. My name is Cheikh. I'm not sure whether my screen, my webcam is okay. Seems like there's a lot of light on my back, but anyway. So very happy to be here today. This is our second session in this series of data analysis centers in the countdown that we've started a couple of weeks ago. So thanks a lot for all the countries who have been able to register and attend this meeting. So this is supposed to be a 1-hour meeting, engaging a bit on some technical aspect that we've been working on recently on health first data analysis. So quickly, we'll be having 3 presentations on the health first data aspect, looking at let me go through my slides so that we are on the same page. So these are the outline. This is the outline that we would like to go through with some general information that we'll be discussing right now about what the purpose of this meeting, the DAC, and the tools and the opportunity that we have in this DAC. And then there is a presentation with Martin Mutua on completeness of adjustment to just go to some real example into how to do that. And then Dr. Maiga will come in to go to the consistency and outlier adjustment in the next few minutes. And then Tis will talk about the denominator, which is one of the key points in this type of analysis that we'll be looking at. And then lastly, I will come back on a few aspects on a related study that we are implementing that's related to COVID assessment, COVID evaluation of impact evaluation. And some of the countries here actually will be part of that study, and I'll talk briefly about that and how to move on and what the next steps are. And then there will be an opportunity also to drop some few questions, either in French or in English, for us to see what your ideas are or what your suggestions or contributions are in this session. And we'll be happy to answer those if time allows. So basically, that's the purpose and the outline of this session. Just remind you that the session is being recorded, so there will be probably a small video out of it to be put on the web and all that to listen to the session. And then the session is also being handled, facilitated in French and in English. So depending on whether you want to listen to the English or the French, feel free to select the right channel down there on the drop-down list so that we are sure we are on the same page. And also all the materials and tools and presentation that will be shared now will be also made available online through a web link that Brittany will provide to you now. I think at this point, maybe those are some broad clarification so that we are sure that we are on the same page. Are you okay? Great. Just to start with this, about computing health statistics from facility data. And in this series of analysis, I think, as I mentioned, this is our second series. The first one focused on equity analysis. This one will be on health analysis. And in the process, we'll be mainly focusing on the end-line part, an end-line analysis. So number one, let's agree on the fact that health first data are the primary source to monitor progress of national plans and annual plan, because all countries have plans, they have plans. And of course, we look at other type of data, but health first data actually is one of the main sources of data that we use in handling, in reviewing this annual plan in the countries. It is mainly used, but often not trusted. And maybe we'll talk about that because there are many reasons why those data are not trusted. And we'll talk about that after. So adjustment is needed. You need to look at the quality, how to improve the quality of those data so that we could get good outcome out of it. And that's why we are here today. That's the purpose of this meeting. We focus on an end line, as I mentioned, what needs to be done to analyze annual data to prepare a report for an annual review. Let's say we have an annual review in this country or that country. If you have all this information from the DHIS system, what needs to be done to make sure that the data are ready to are yet ready to be analyzed and are yet ready to be looked at. And with a focus on the performance, of course, how are we doing at national level, at subnational level also, district and other subnational level. So there are two components. One is to assess the quality of the reported data, because that's the first step, and we'll take you through the steps, what to do to assess the quality of those data. That's the focus of the first presentation. What are the outliers, what are the inconsistencies and all that, and how to navigate through that. And the other thing is now the denominator, because one thing is to have the indicator, but another thing is to also agree on the denominator. What denominator are we using? Because that's where there's a problem, because we need to know our population, we need to know who are we supposed to be receiving the services in our situation. And there, depending on the country, depending on the data that you have, you may end up not using the right denominator. And there's a presentation that will focus on that in the next few minutes. Basically, the problem is just summarized in these slides, and it's important for us to be on the same page and understand this slide very well. Reported data by health facility on events actually are basically too noisy. A lot of information, a lot of errors, a lot of mistakes going on. And there, it's important that the assessment would be done on the quality to see at what level of quality we are and what to be done to improve that quality. Okay, and that's the first part of this meeting. And adjustment may be needed some time to make sure that the inconsistencies are addressed very well. And there's a process, there's a way we do that, and that's the focus of the first component of this meeting. The other thing is, as I mentioned, related to denominators. That's also very important, because reliable population coverage indicators cannot be computed because of target population are not known, because we don't know basically. For instance, we talk about in the population age 0, let's say 4 years. It's not easy to know it, because we only rely on census and other type of survey, and sometimes the data are not very well relevant. So, but there are something to be done that we could do to at least estimate them very reliably and have a proper estimate out of that. So that's the second purpose, that's the second focus of this session. And there's a full presentation on that. So the two components, the two activities, the two actions will lead now to getting reliable information from DHIS to data. And that's how we would like to provide our contribution to support countries into doing that. And probably most of the countries will use the same method in preparing their review and their annual report. So this slide is important. Just look at it that way and make sure that you understand it, so that we are sure that we are on the same page. I'll stop there for now and invite my first colleague, Martin Mutua, to talk about the overview of the data quality assessment and how we are doing that data quality assessment. What are the steps that we'll go through, and it will lead to which type of output. So let me invite Martin Mutua to talk about
that. Thank you so much, Cheikh. So I'll briefly discuss the first step one need to do when starting to work on health facility data set. So I'll be talking about completeness as well as adjusting, in terms of number of events. So in the figure below, the figure you're seeing there is summarizes the process of assessing data quality for health facility data. Basically, they are divided into two broad areas. The first, on your left-hand side, is a issue to do with the numerator, and here we have data quality 1, 2, and 3, is on the issue with to do with the denominator, which we'll be looking at the DQ4. I'll take you through the first part, that's the DQ1, assessing the completeness of reporting, and my colleagues will take over through the rest of the process. Next slide. So incomplete reporting of events by health facilities is a major data quality issue affecting the analysis stage. And this is, Cheikh has alluded to that, and estimation of the levels and the trends of coverage of indicators are heavily affected by the levels of complete reporting. Reporting data is available in the DHS2 at a monthly level, and this can be used to assess quality of data and make adjustment before you produce your indicators. And this can be done using reporting rate for reporting form, or you can also do an average of key reporting form. For example, ANC, immunization deliveries, as well as OPD visits. In the next slide, Cheikh. Here you're seeing an example of how incomplete reporting can impact our analysis. In this analysis, we are looking at 2 counties in Kenya. That's Kilifi, which has very high reporting rates, above 85 and increasing over time, while Mandera has a very low reporting rate. So we can assess the impact of non-reporting by comparing 2 extreme adjustment options or methods for the 2 counties. Here we are assuming, the first option is assuming that the non-reporting facility do not offer any of the services. This is depicted in the blue line in the graphs. And then we have the other second option is services at the same level as the reporting facility. And this is depicted in the red color. So if you can see on your right-hand side, after adjusting using the 2 methods, you're seeing for Kilifi, which has a very high reporting rate, there's small impact on the number of events we'll be using to produce the indicators. But if you look down for Mandera, where we have a low reporting rate, you see, depending on the method you're using, it impacts very much. Like there's a big difference whether you're using the first option where you're assuming the non-reporting facilities that do not offer any of the services compared to the other one. So this is something we need to, to put in mind while you are while you're adjusting. Next slide, Cheikh. So in the example, we've looked at 2 counties, and then we've looked at 2 extreme, and that's when you're assuming the non-reporting facilities, they don't offer any services, or they're offering services at the same level as the reporting facilities, just the reporting the events. However, adjustment mainly depend on the assumption about the number of events between the 2 groups, the reporting and non-reporting facilities. So we use the formula indicated there to adjust for, for non-reporting. So the formula is that you get the n number of events adjusted is equal to multiplied by a constant. And the constant is defined by the reporting rates as well as a K factor, which is, we call it an adjustment. We've done for Mandera and Kilifi, and you get different results. If you see in the next slides, we'll define how to define K for your analysis. So, and this again, most of the time, the choice is based on consideration by the analyst or someone working on the data. Like you need to know what kind of facilities are reporting and what are their characteristics. So basically the K can vary from 0 when we have, we assume the non-reporting facilities, they don't offer any services. And then it can go up to the non-reporting facilities. They also, I mean, they're offering the services at the same level as the reporting facilities. And as I said, this is most of the time you sit down as an analyst to sort of choose which value of K to use. And sometimes it is informed by some characteristics. For example, there's a reporting rates, links to supplies of the services, or could it be due to vaccine stockout in terms of when you're looking at the coverage of vaccine, or as well as you can look at the large hospitals reporting. And what role do they play in terms of inform the choice of K? And this is done at the time of doing the analysis. I think I'll invite now the next speaker. I think it's Maiga to take through from there. Thank you.
Thanks, Martin. Maiga.
Hi, good morning, everyone, and good evening, everyone. Thank you, Cheikh. I will keep presenting the health facility data quality assessment and adjustment with a focus on the internal consistency over time, as well as the consistency between health intervention or services. These are key and essential for the systematic data quality assessment of the reported data, and should also be conducted for the end-line analysis to prepare a report or for in-depth analysis. Next slide, please. Let's go first through the consistency over time of our monthly data. As already mentioned, reported health facility data are too noisy. And a routine data quality review of monthly data should be conducted to detect outliers which are reported data, which seems abnormal, aberrant, as they differ from the other value or reported data. It's good to keep in mind that non-detected outliers can cause serious time trends problem. Before the analysis stage, data manager can use the WHO data quality module, which is now incorporated into the DHS2 tool to identify outlier and assess internal or external consistency of data. In addition to the routine data quality review, you should plan to conduct an additional assessment to check whether any major outliers are still remaining in your data. Extreme outliers should be identified, corrected, and and you should report explicitly whether or not there are remaining major outliers in the data set. Ideally, we expect a non-outlier at the end of the day. For instance, a major outlier for monthly aggregate data in a given year can be identified using a modified Z-score with a threshold of 3.5 or standard deviation from the median of a year, for instance. The time trend consistency can also be conducted with annual data. Consistency over time, but now focusing down on annual data. In general, we expect limited variation in the reported number from here to here for help services or interventions. If there is a lot of variations and there is no good explanations, data are considered in that case as noisy and may have data quality issues in some years. For annual data, extreme outlier can be defined as any number in the data set with the absolute value of modified z-score exceeding 2 standard deviations in the current year compared to the preceding 3 years to see if the latest year can be considered as an outlier compared to the preceding years. We are now using the modified z-score since it's a most appropriate estimator for a small sample, and also because it's provide a more robust statistical detection of outlier than the traditional z-score, which is based on the mean. Next slide, please. Okay, these are here an example of how we can, for instance, detect outlier for monthly data. This is the first table, and for the second table, we have an example of identification of a outlier for the given year compared to a free preceding year. And that can be done for different health services. Here we have example for ENC1, DTP3, and also outpatient department services. And after now using our threshold, here with threshold to detect measured outlier was 3.5 standard deviation from the median. Okay, we were able to see the number of districts with non-outlier. Okay, for instance, for ANC1, this is our example. And also, we are also able to see the number of value which are considered as outlier for monthly data. The number of districts with at least one monthly data that can be considered as an outlier, or the number of districts for which there are some value that can be considered as outlier, but we have more than one outlier. This is something very interesting to try to see whether we should be focusing on just one outlier, or we should be focusing on more than one outlier to decide on which one should be the focus for the inline analysis and also for potential corrections. The second table is something similar, but presenting data for annual data. Okay, here, unfortunately, you are able to see only the data for ANC1. Okay, we have the same as the first one since we presented the data quality for ANC1, DTP3, and ODP. So looking just at the first one, okay, we are able to see that how many the percentage of districts with extreme outlier for annual data based on the modified z-score, which can be considered as outliers. Please, next. But now we should be cautious while we try to interpret outlier, and also we should try to see if there are not some factors which are influencing the data in also and for adjustment. So first, fluctuation in the service delivery may not necessarily be the result of data quality issues. Okay, most of the time we have some data quality issues that can explain the different variations but we should also keep in mind that fluctuations are not necessarily the result of data quality issue. We may have some factor like stock out or some change in programmatic activities like vaccination campaign, okay, which can impact on the level of a services for a given year or for a given month. We should also take into account of the impact of some factor, contextual factor, which can be, for instance, a seasonal disease, which can explain the level of, for instance, hospitalization or a outpatient department services. And also, we may also have the impact of population migrations, which can also impact on the level of services provided during a given month or certain period or a year. So it is very important to have a good knowledge of the context and a program data for interpretations of trend analysis. And we also expect some annual increase in services due to the growth of population and improvement in the service coverage. Next, please. Okay, here is an example of internal consistency between the number of ANC1 and DTP3, or also of the consistency between DTP3 and DTP1 and DTP3. These have a common internal consistency of between interventions people usually try to conduct. Since we expect to have some very close number of DTP1 and DTP3, and also we also expect to have some coherence between the number of ANC1 and DTP1 services. So we conduct now internal consistency by calculating the absolute difference between the expected and the reported ratio of the two indicators. The expected ratio is obtained from survey data, while the reported ratio is obtained from the health facility data. And we can now try to have some threshold and going from a difference less than 5. Okay, in that case, we expect that we have a good internal consistency between both interventions, for instance, in this example, DTP1 and DTP3. But if the difference is between 5 and 15%, in that case now we say that it's something that is different. But if the difference is above 15%, this is something very different. It means that we may have data quality issues. This is an example for DTP1 and DTP3, but we are also able to do the same example for ANC1 and DTP1. We can also use a scatter diagram, okay, to also try to see how the data quality are between ANC1 and DTP1 or between DTP1 and DTP3. And the next slide is going to show this example. So this is an example of the relationship we expect between ANC1 services and DTP1 for a given year. The different dots are district. Okay, so we are able to see the reported number of ANC1 compared to the reported number of DTP1 for a given year. So the better, the higher the correlations, the better the consistency between the different interventions we compare. Thank you very much. Please, over to you.
Thanks a lot, Maiga. So Tis, over to you.
Thank you, Cheikh. So to be able to, next slide, please. And so I'm going to talk about denominators. Next slide, yes. So to be able to compute population coverage rates, we not only need good numerators from the facility data, but also an estimate of the denominator or target population. So we need to know the size of the population, the number of pregnancies, live births, infants, etc. So I'll be talking about the right side of this diagram, which is a challenge for all programs. Next slide. So here's just an example, which I'm sure many of you have come across. You compute based on the DHIS2 data, the coverage of the first dose of DPT vaccination in a district, and it's 130%. The reactions of the users are clear, impossible. And the results is often that no one really believes the DHIS2 based coverage statistic. So what is wrong? Well, first of all, it could be that the reported numbers of vaccinations are wrong, the numerator. It could also be that the estimated denominator or target population, here the infants eligible for immunization, are wrong, or both are wrong. So how can we examine the denominator issue? Next slide. So there are two main methods in an end-line analysis that to inform annual reviews that we can use. First, we can look at the population projections from the national census, and the DHIS2 denominators that are in the system are often the same, but not always. And second, we can use facility data from the DHIS2 to estimate the target populations on the ANC first visit or on the first vaccination, BCG or pentavalent or DPT first dose. So let us look at the population projections first. So the census is the main source for population by age and sex for the country and subnational areas. Some national statistical offices provide live birth projections, but the projections have errors if the census wasn't accurate, excuse me, or projection assumptions are not correct. And there are two things to keep in mind. One is the longer ago the census was, the less accurate the projection. And second, the smaller the population unit, like a district versus a region or national, the smaller, the more uncertainty. The DHIS2 denominators are usually based on total population by age and sex, live birth, etc. Based on the population projections, they should be the same, but often they're actually not. So it's always good to check and compare the two. The second method is based on the DHIS2 reported numbers, and the reasoning is simple. The coverage of BCG or ANC first visit or DPT1 is over 90% in many countries. And we can know that because of DHS and MIX and other surveys. And they're high in almost every province or district. Therefore, the DHIS2 reported number of BCG or ANC1 or DPT1 vaccination is a good indicator of the target population, pregnant women, live birth, etc. If the data are complete that are reported, and after adjustment for reporting completeness, as we saw from Martin, and if the data quality of the reported data is good enough, and that we saw how to assess that in what Maiga presented. We only have to add those who never use the services to the data. So an example, if we have 9,500 DPT1 injections reported for a district and the coverage in the survey is actually also 95%, then the target population will actually be 10,000 infants. So here is an example of the levels and trends in national denominators in two countries, Tanzania on the left and Uganda on the right. The graphs show the number of live births estimated according to different methods in a 5-year period. The orange dotted line are based on the official, actually they're red, sorry, I'm a little colorblind. So the red dotted line are based on the official population projections. The yellow and the green lines are the estimated number of live births from the DHIS2 data on the reported numbers of ANC1 and on the reported number of penta or DPT1 vaccination. So if you look at Tanzania, you see there's some consistency between the two methods. We expect them to be very close. But the blue line, which is actually the DHIS2 denominator, is far off from what is reported in the system for ANC1 or DPT1. And so one gets many coverages above 100%. On the right in Uganda, the consistency is actually much poorer between the population projection, which seems to be too low. That's why we also showed the dotted line, which is the UN population projection, and the two live births based on the reported services, which are much too high. Penta 1 seems to be very high, about 1.8 million live births, if we use that, which may be over-reporting of Penta, because it's even higher than ANC1. So this is the puzzle that we have to make sense of. Next one. So what can we do? So we need to do systematic assessment, and there are 5 steps outlined here. So first is to assess the population projections and the denominators used in DHIS2. Check the population growth rates at national and subnational level. Check the crude birth rate from the census and compare the crude birth rate with the one from DHS, which can be found in Stat Compiler, also for the subnational areas. Compute the live births with different crude birth rates and official population projections. So we get a good sense of the population projection quality. The second is to estimate target population from live birth, pregnancies, deliveries, birth, and eligible infants from the projections. So here we need to make some assumptions about abortions, stillbirth, neonatal mortality, and twinning rates. Some we can get from the surveys, some we use international data. The third step is to compute coverage for near 100% coverage interventions. We already spoke about first antenatal visit, first immunization. From the DHIS2 data and the denominators derived from the population projections. So here, if many districts have coverage that is too high, using these population projections, then these population projections are not likely to be good. Same, if they're too low, there is also a problem, of course. Fourth, then, consider the health facility database denominators if the population projections are problematic. The choice of whether one uses ANC1 or BCG or Penta 1 depends on the data quality assessment. For instance, coverage of birth in health facilities, which is the total birth in health facilities in DHIS2, divided by the total number of births estimated from the reported ANC visits, including the non-users. And then finally, an external comparison with survey data is absolutely critical, because if, for instance, we look at delivery coverage and the data are far off, then we have a problem still. So it's a good external check. Our experience is that often we end up using ANC1 or Penta 1 derived denominators for many indicators, especially at the district level. Thank you.
Thanks a lot, Tis. I think it has been very helpful. And just to confirm that with everyone, that all the resources are available from the website. And I think there may be some, you could see here some papers we've published recently in 2019 and 2017. And then there are some tools, Excel sheet and all that we've prepared that are available. I think Brittany, I'm sure, may have shared the link on the chat box with all of you to download, to access these resources. And this is also, these are part of the tools, I think. Please correct me if I'm wrong. I think these are some of the tools, how it is displayed in the dashboard data quality assessment that could be used to assess data quality of the DHIS. And there is a way and resource that we've already provided.
Yeah, maybe Cheikh, if you just could go back to the previous one. Just on the resources there are certain publications and it's still expanding. Also, as a countdown team, we are learning very much from in this field, and we hope we're working with you intensively on the DHIS2 data. We can learn a lot more in the coming 2 years. But the two tools are indeed the Excel spreadsheet that you showed in the following slide, but we have used this in the 4 workshops that APHRC and Countdown organized in 2019. It's a spreadsheet tool where you can enter the district data and examine the kind of indicators that Martin and Maiga showed. There's also a crude data code that we've used now in 4 countries, and we're working on this. But this is something that if you're interested, we're really happy to share and to work with you on applying that in your own country. And then there are the modules that WHO has done, which are particularly for correcting the data when they come from the facilities and the districts. And whereas here we're focusing really on when everything comes together, how do we create a clean data set and get the best statistics? I don't know, Cheikh, shall we also say something about the COVID study?
Yeah, sure. And I think that was the next point in the agenda. Yeah, just to describe, talk a bit about this COVID-19 study that some of you have heard about, and I think there's an email that we've sent a request for countries to show interest into that study. Actually, basically, the tool that we are presenting will be definitely adjusted or amended slightly, and to be used to collect the data through DHIS platform, and then to be compiled, analyzed the way we have described. So I think most of the countries will have interest on that. And you'll be hearing from us very soon into confirming the date of the meeting and further work that we are planning this month, actually in February. So the idea is really to use the same technique, but to assess the impact of COVID, looking at elementary services and all that in your own country. So far, I think 9 countries or so, or 10 around there, have confirmed participation in that study. So that was above our expectation, but in case some are really last minute interested, so we could look at that closely. So that was one of the things I wanted to clarify. But I think at this point, we would like also to welcome a few questions. I've seen some questions on the chat box that are important to look at. So Brittany, correct me if I've missed some, but I think those that are on the chat box could be looked at first, and probably could have a round of few questions. Safia have a question, I think, to Martin. Is there a way to set a different adjustment factor for different non-reporting facilities? It may not be entirely accurate to assume the same K for all non-reporting facility depending. So Martin, you may take that one probably and see. I think that's the only question I've seen so far. Martin, would you like to expand on that?
Yeah, I can give a try, and then maybe he can come in as well. Yeah, so I think that's one of the challenges of but to give a short answer, like it's yes, it's possible, but especially when you're doing analysis at a health facility level. But when it comes to when you're doing analysis at district or subnational level, it becomes very difficult to have each and every health facility with a different K. And normally, so what you do is just to as I mentioned before, that the K, you're being determined by, the analysis experts. So you can be able to see on average which K to use, but it's possible to use a K for every health facility when you're doing analysis at a health facility level. Thank you.
Great, thanks, Martin. I am not sure, maybe Tis, I will come back to you if you have anything to add. But I've seen another question here from Daniel Friedman, who say one question about data. consistency analysis, slide 17, has a table comparing reported versus expected ratio. Could you clarify how the expected ratio was derived? We should go back to that slide. I'm not sure whether I have it. Yeah, is it this one? I think it should be this one. Yeah, it's this one, right?
Yeah.
Yeah. So Marty, Maiga, maybe you could.
Yeah, sure. Yeah. Due to time constraint, I was not able to try to dig in, but happy that there is this question. So this is an opportunity to provide more detail on this. The expected ratio is obtained from the most recent national survey conducted in the country or in the same setting. So people you usually try to draw data from a mixed survey or from DHS data. So for instance, for DTP1 and DTP3 expected ratio, it's just to devise of a percentage of coverage for DTP1 from the DHS survey, for instance, by the coverage rate for DTP3, and we obtain now the expected ratio. And the reported ratio now it's based on dividing the reported number of a given services, for instance, DTP1, divided by the reported number of DTP3 services. For instance, we have a reported ratio. So in summary, reported ratio is from DHS2 data, and expected ratio is from coverage data from a recent survey conducted in the country or in the similar setting.
Thanks, Maiga. I think this has been one of the questions that people have asked in several of our convening about how you get the K, what's the rationale, what's the background, and all that. I think you've tried to answer that very well. I know Agbesi have also an idea on that. Maybe we should take other few questions apart from the chat, because from the chat box I'm not seeing any more questions. But maybe we could have one or two questions before now we go back to Tis to come up. Yeah, any question? If you raise your hand, I will see it. Or maybe, yeah. No question? All right. Agbesi, there's something you're trying to explain on the chat. I'm not sure whether you want to clarify that before Tis come in. Is Agbesi here listening to us?
Yes. No. Good afternoon. No, on the K, I just wanted to clarify the confusion. My understanding is that the K is assumed about services that that may be provided but not reported on. But if we break it down at facility, individual facility, then for each facility, what I'm saying is for each facility, we know the reporting status and the service provision status of the facility. So the K may not be relevant at that level. Maybe when it's grouped by type of facility, if you're looking at hospital, health centers, or then maybe it may be relevant. To me, individually, it will be difficult to set up K individually for each facility.
Thanks, Agbesi. That's quite a good point. And I think if you build on your own experiences, if you look at country data, I think you could definitely have a quick answer to what the K may look like, depending on the type of data facility that you are dealing with. So that's why actually our question actually was to say, building on your own experiences, actually, what you are doing, analysis you are doing now, whether you have been engaged in such type of analysis, or you are doing something else, or maybe you want to learn more about these methods or all that. So if any of you have a specific case to share on this, I think we'll be glad to take that. Before we get to that, probably Tis, I'm not sure whether you want to summarize a bit the point that we've had before we move to the next slide.
Sure, and maybe, Cheikh, you can pull up that diagram that you showed in the beginning with the two streams. So,
is it this one?
The first, yeah, that one. So basically, I think we're all struggling with trying to get annual coverage data for immunization, deliveries, all sorts of interventions at the district level. I think that's what everybody wants. And the DHIS2 data, I think, are giving us a huge opportunity to do better. We know that there are, problems in the reported data, as we say, that they're noisy, but we can systematically look at the data. And so, as Martin showed, completeness is important. And in fact, if completeness is below 70% or so, it's very difficult to estimate coverage because there's 30% of the facilities that we have to make a guess, and it will be hard. But in most countries now, it's over 85% reporting. So we can do much better there. And the value K is from the debates that we've seen in many countries now. First of all, it differs by service. So immunization usually has a smaller adjustment factor than deliveries because immunization numbers are often tied to vaccine delivery. So they have to be more complete than, for instance, deliveries where the private sector can play a role and not report. So the value of K, though, that is mostly chosen is something like 0.025, 0.25 or 0.5. So meaning if you say you pick 0.5, half of the non-reporting facilities have half of the numbers that the reporting facilities have. So it says something that if you don't report. But this is, as Martin said, a discussion in countries. Then second, there's this detection of outliers and inconsistencies that Maiga talked about. And this is tough because at the district level, there's quite a lot of noise in the data naturally. 1 month, there's a lot of work, and the next month, there isn't. And so is it an error or is it not? So all we do here is weed out those big differences where somebody put an extra 0 or completely wrongly entered the numbers wrongly. So I think that's important. And then we have the numerators. Now, the denominators is always a big challenge for everybody because the census projections are quite good in some countries, but they are not good enough for our denominators in many instances. And sometimes there's a systematic error that the population census is actually too low, considered too low. So what do you do if you have 140,000 antenatal visits, but your population says you should only have 100,000? You say the coverage is 140%, or do you try to work with that? And I think we have good experience with the facility data derived denominator. So looking at ANC1, Penta1, or DPT1, or BCG. So for instance, in Rwanda, they had that problem and they decided to go for BCG. In Kenya, Tanzania, and Zambia, we also looked at this, and we saw different qualities in the population projections, but we went for a denominator derived from either ANC1 or from the immunizations, particularly at the district level. So, doing this it's a bit of a trial and error. So we have the Excel tool that we've used in the workshops, which we think is useful. But also with this data code, and there was a question, can we, change the code and so on? Absolutely, it is there to change. It's only a start. So working together on improving this and making it also, of course, most relevant to the country is necessary. So those things we also hope to expand in the coming months, and we hope many of you will participate in the COVID-related study, which is actually a little bit different from what we presented here, the annual reviews, which looks at annual data, because there we're looking only at the monthly numbers. So it's the upper side part of this graph, and with some modified techniques to really try to predict as well as possible how many visits of, say, antenatal care or immunization or deliveries can we expect in 2020, and how many were there in fact, to show whether there was any impact of lockdowns or anything else. So that is the aim of this. And then from there, we can take this further into the kind of analysis that we've done here. Thank you, Cheikh.
Thanks, Steve. Thanks, Steve. I think that's quite comprehensive. And you also answered the question from Mahamadi, who was asking about how to get access to the Stata code. And yeah, I think the codes are actually available. And I think if not yet sent to you, it will be sent to you from the chat box or from the report. And it's actually to be changed, as she's mentioned, depending on your country, you could adjust the codes the way you would expect. The only thing will be for you to have a basic knowledge on Stata. Otherwise, you can mess the codes. Otherwise, that's quite important. I think, as I mentioned, the upcoming study will be will build on these knowledge, these tools, and but maybe change slightly. And then what we said is this is one of our work, just the first workshop. Remember, this process is actually hectic, could be very demanding in terms of what to do, but also this example could be very different from one country to another. So this is our first workshop. We are aiming to have many workshops in the coming weeks to look at more complex advanced things on this, and probably engaging also more with those who really are interested. Because now that you see the bigger picture, depending on whether you are doing it or not, or you want to go beyond what we've said, you could have more sessions to clarify a few things. We are yet, we are almost finishing, but I think Maiga or Martin may want to address one or few issues before we conclude, assuming we don't have more questions. So Maiga.
No, I mean that TIS provide a good summary from the identification of a problem assessment until getting the final data set, the slide you are showing. So it's very well done. And as you said as well, I mean that we are going to have additional meetings and workshops to try to go in depth in some explanation and also further information related to health facility data analysis. So just to end with thanking everybody.
Great, Maiga. We really thank you also for that. Martin, any insight on?
I think you and Tis have summarized it well. And just to say that I'm looking forward to the countries which have shown interest in the COVID analysis using the DHIS2 data, which will be will be applying most of this data quality analysis. Thank you.
Great, thank you so much. And just to conclude that, we really appreciate your time and you showing interest in this type of analysis. As I mentioned, depending on whether you have already completed your annual reviews or not, you may be already doing this or doing actually more advanced things. So feel free to engage, and we are really happy to provide further support either through our DACs or through the country collaboration, because each country has a technical lead and team that is working together. So feel free to engage directly with us. And once we confirm the next session, we'll definitely engage with you and share all the resources. There will be a report on this workshop, on this session that you will be seeing from our website. And all the tools will be made available there in presentations. So at this point, we'd like to thank you very much for your time and wish you a very good afternoon and have a great day. Thanks. Bye-bye.
Thank you.
Thank you.
Thank you.
Merci.
Great, thank you. Merci bien, merci bien.
Merci.
Merci.
Great, thanks.
Thanks.
All right.
Merci, c'est gentil.
beaucoup.